start with, they'll do some introductions, talk a little bit about how they got into this and why they're here. And then I have a bunch of little questions here to just start the discussion, and I think hopefully I might not have to ask too many questions. All right, so everybody introduce yourselves and why you're here. And
hello. Hi, good evening. Michael Greeley, I'm the token venture capitalist on the panel. I've been in the venture world for 25 years. Was the founder of a firm in town called Flybridge. Many of you know the firm. I recently raised a healthcare tech fund. It's called Foundation. So why am I here? I think it's because Sanjay invited me. And I feel like I've been on the lunatic fringe for 15 years, investing in technologies, convergence of healthcare and IT. Finally, I think now this is the great decade, so I'm excited to be part of the community.
Good evening, everyone. My name is Alan Kamer. I am the Chief Commercial Officer of a division in Optum called Optum Analytics, and I'm a co-founder of a company called Incubators, which was based here in Boston, that was focused on big data and analytics for the healthcare market. And I've spent over 20 years in healthcare and have focused really on the problem of taking information, disparate information, and trying to make sense about what's going on in healthcare, ultimately with the goal of improving the quality, cost, and outcomes associated with the delivery of care. And I'm here tonight to really learn from others in the space. There's so much interesting activity going on here, whether it's technology, whether it's data, whether it's policy or investing. And I often find that these are terrific opportunities to network with other people and to learn new things, learn about some interesting companies, learn some interesting technology, or really hear what some other companies might be up to. So I'm looking forward to the discussion tonight.
Hi, everyone. I'm Chris Joshi. I'm the Executive Vice President and General Manager for Products at Anyon. Anyon is, in my opinion, the largest healthcare data company that no one's ever heard of. Just to give you a flavor, we carried about $1 trillion worth of healthcare claims and payments last year. We connect almost every provider, payer, pharmacy, and lab in the country. And we're sitting behind a lot of the transactional systems like the EMRs and practice management systems, lab systems. We're the connectivity that gets the transaction from point A to point B and back. So that's what we do. And I want to ask you all a question. So how many of you have health insurance? Health plans? I expect almost all hands to go up. And they did. How many of you have high deductible health plans? Few hands, very good. So that's a trend, and it's going to grow. And what it's driving is just a massive amount of consumerization and consumer involvement in healthcare. These are people who are realizing that they're better off paying out of pocket for small expenses and relying on healthcare for health insurance for large expenses. Unfortunately, the providers and the payers are not really well set up to create these kinds of plans and manage and make the experience for the consumer who's now more out of pocket seamless. So if I were to ask how many of you have used Uber? All right, large number, and hopefully growing. And I'm sure if you use Uber, you probably start wondering, why can't I have this experience everywhere? Why can't I walk into my doctor's office and have my registration information automatically provided? The doctor to tell me how much it's going to cost me for this visit, because now I have a high deductible health plan and I'm going to pay the first $5,000 out of pocket. I really want to know. And when I leave, that I don't get these 5 different bills that I can't make sense of at the end of the week, that I don't end up paying half the time and everybody loses. Why wouldn't you have an Uber-like experience that connects all these things together? Well, I think that's a good question. And we're out to try to answer that and address that, because no one really has a great solution to that problem. There's so many moving parts. But at Anyon, we have a lot of the core ingredients that sit across the different systems, the payment systems, the registration systems, the ordering systems, the cleaning systems, and we're trying to make that whole experience seamless. And did I mention we have tons and tons of data? And I'm based out here in Cambridge. I love coming to events like this and meeting people who are doing stuff with big data. And we're also hiring. So if you're interested in doing cool stuff with great big data stuff, platforms, come talk to me.
My name is Tim Andrews. I work with Booz Allen Hamilton in healthcare and big data. I got into this because I lived in Boston about 12 years ago. I said, no, I'm tired of traveling because I did high tech for many years. I worked on the original Macintosh way back when. I spent a lot of time on Silicon Valley, and I said, okay, healthcare is big, it's finally getting technological. I should go into healthcare and biotech. It's right here in Boston. So that's what I did. And that part worked out great, except the part about staying here in Boston. So I still travel a lot, but I'm here tonight, and every once in a while I get back to Boston. But I've been interested because I do think the data and technology is really there. It's starting to have an impact just now. It's going to be an issue for decades and decades. And I have to say, I won't say, Chris, you're going to slide, but I will say, I will ask the other question. How many people like going to the doctor? How many people have been sick in the last year? Did you go to, how many people who were sick in the last year went to the doctor? Were you thrilled about going to the doctor? Keep your hands up. Did you enjoy it? Okay. So I would say the other side of the high deductible experience I would take issue with, because in fact, I don't think overutilization and consumerization is necessarily the answer to healthcare issues. There is definitely overutilization, overspending, crazy spending, but it's mostly not because people are abusing the system and because they'll suddenly get smarter if they have to pay $5,000 out of their pocket. In fact, a lot of the evidence shows that people who need treatment will not go to the doctor and will end up costing us a lot more money because they'll be sicker down the road. It's a much more complicated story than that. So just to raise the issues on both sides.
Awesome. So I want to kick it off with you guys. So Alan and Chris. There's this trend of payers bringing in analytics firms. There's payers getting more use out of their data. Payers traditionally were clearinghouses and didn't really care about the patient. Now you guys here are doing so much talking about the patient, setting up labs here in Cambridge to provide better data for better care. How has that changed? I mean, where do you see that going? I mean, do you really think payers are the right people to do this?
So I will start. Informatics was acquired by United Health Group last January 2013. And United Health Group has two businesses, United Healthcare, the nation's largest insurer, and Optum. And they are distinct and separate in many ways. Optum is an organization that's focused on making the healthcare delivery system work better. They have several hundred payers as clients, so even payers that are competing with United Healthcare. And data and information and customers and IP are really separate and distinct between the organizations. Our data from our providers does not flow back into United's own data warehouse. And so, yes, a payer organization.
Is that legal or by design or by organizational?
It's a combination of all. It's by design. There are, of course, legal requirements when we work with providers or business associates, so we have access to patient-identifiable information and physician-identifiable information. And nothing is more important to us than protecting that information and keeping it confidential and directed towards that particular provider and only that provider. Information is certainly power, and it's certainly currency to better understand what's going on. The entire healthcare delivery system, payers, providers, life sciences companies, government, investors need information to better allocate resources and better direct investments where it's needed and where appropriate. And part of the big deficiencies of our healthcare system and why it's such a great percentage of our GDP has been scarcity of information. And I think those organizations that are able to turn the mass of raw disparate material that is big data in healthcare and refine that and turn it into finished, quote-unquote, good data to better allow answers to question what treatments are appropriate for which patients under what circumstances will really solve the big issues this country is facing related to healthcare. And by doing so, you need to connect information in many different ways. And I would say former enemies, if you will, become bedfellows in the state of healthcare.
But the real question for me is, when do I, as a patient, get to see all that? Because I have yet to find my own information. So one great thing about the meaningful use is, you need to make it available to patients, right? So who here really goes to a hospital portal to look at their data, and how easy is it to get to, right? So no one's really looking at their data, even though meaningful use, everybody's all happy checking off that they can do that. Nobody's using it. So yes, it's great the talk that you guys have, but is it really happening, or is it just like checkboxes on your products?
Well, I'll start by just making an observation. What is a payer? When you think of payers, United comes to mind, or Aetna or Cigna or Blues. The reality is most providers are becoming payers. They're all creating their own health plan. If you're a big enough provider, you're probably creating your own health plan at this point and turning into an IDN. So I think the whole idea that you've got these payers and providers, you're going to now see a spectrum. And add to that the further observation that Medicare is a big payer. It's the government. And they're so big that risk management for them is essentially like population management, right? The entire population. And then think about the fact that there's a lot more out-of-pocket payment now happening. So whether people like it or not, the people who have high deductible plans or who have HSAs and HRAs, they're starting to use those more and actually starting to take on some risk at a small scale, right? So it's no longer a question of who's a payer, who's best positioned. But that issue aside, if you look at the two big parts of healthcare, the clinical side, how do you keep people healthier, I think that's one set of issues. The other side is how do you make healthcare more efficient? And there are a lot of other things you can do which are very boring. Things like eliminating paper. And it sounds like in 2013, paper would be totally eliminated out of healthcare. The reality is, you'd be shocked how many bills and statements are printed and mailed every day. We do a lot of that, so I know. And we send tens of millions of dollars to the U.S. Post Office. Yes, they need that money, but boy, this isn't the way they should be. They should be growing. So by actually automating payments, automating the user experience, and making it more seamless, we can take that 30 cents on the dollar that we spend on just administrative processing. It is unconscionable that we spend that much on just getting the revenue cycle to just wheels to turn in healthcare. Right? I think there's a huge opportunity to reduce that. And frankly, that's going to require collaboration between all the stakeholders, the payers, the providers, even the government, all working together, because no one party actually can fix the system by themselves. But if people come together, and we see at Anyon, we see our unique role in all of that being the connectors. We talk to all these stakeholders, and today, year after year, we can show that we drive more payments to electronic from paper. We do more e-delivery. You all get e-delivery of other bills, right? How often do you get e-delivery of your healthcare bills? It's waiting to happen, and we're just now doing it. A lot of other folks are doing it as well. But that's the low-hanging fruit, and you'll see a lot of that being captured in the next couple of years.
So the question, I think, was about why doesn't it feel like Uber, right? And I think, it's actually changing, and there are lots of reasons it's the way it is. We can have a long conversation about that. But I will say, actually, I think this area is pretty interesting because, this area is quite unusual. The rate of EHR use was over 60% before the meaningful use program started in Massachusetts. This area has all the academic medical centers, so I get emails from my doctor with all my lab results and we log into their portal, so I do. I didn't do it because I'm a geek and I'm in healthcare. I did it because they sent me an email and said your lab results are there. And you made it really easy to collect and just go there. So it's not so individual institutions, particularly here, I think are in leadership roles. So if you take Partner Vanguard, Atrius, Partners, Beth Israel, go down the list. They're pretty sophisticated at this point about getting things out there. Even some of them have started out electronic scheduling. So you're starting to get that sort of basic stuff in place. It's still kind of crude. It's still in the early days. But it's actually making a lot of progress here. It's not nationwide. Here, I think it's kind of unusual, but you can see sort of a leading edge of it here.
Can you talk about the opposite, right? So here, I go to like HIMSS. Who was at HIMSS? Did anybody go to HIMSS this year, last year, whatever? I have to keep reminding myself that when I was a. Do you see, are there, like, when you go to bed at night, or you don't, because you just came back from Tokyo, so you haven't slept in, whatever, 40 hours, and you're off to San Francisco again, so another 24 hours of not sleeping. But one thing that keeps occurring in my mind is that, we have a lot of these startup, Rock Health and Healthbox and all these, that do a lot of competitions or hack fests that happen in a weekend, or they have a class for 3 months. And I feel that a lot of the incubation time for real data-driven healthcare process-changing things require a longer incubation, but also require maybe a closer connection with the people who have data, like within us. So, how do we overcome that? Like, we want to, we did some survey about barriers to analytics, and the first one, of course, is data, but the other ones were organizational. So there's organizations out there that don't know how to use data, that don't know what to do when they get a result, right? We were talking about what happens when you get a result and you don't know what to do with it. Don't have the skills, yet we have all these small startups who have those skills in spades, that thrive in spades. How do we bring them together in a trusted way where those people have access to the data and the systems have access to that external innovation?
So you should talk about Optum Labs, that's how we do it.
Yeah, I think we have experience in a couple of those things. When Humanica was started, it was probably one of the key things that we did initially was establish some close relationships with some provider customers, so some hospitals and some medical groups. We also struck a partnership with the American Medical Group Association that really served as a partner by which we could help build our products, get feedback, have invested customers who were willing to spend the time with us, willing to help take our ideas, our concepts, our early versions of the product and provide input along the way so we could improve them and really be ready to scale for a much wider distribution. And so clearly our relationship with providers, both through the AMGA and on our own, was paramount to our success in being able to grow quickly and have referenceable provider organizations that will say, we use the product to do this. This is the business problem we solve. We were able to identify patients who weren't coded by our physicians and nurses that represented an opportunity for us both to increase revenue by bringing those patients back in for care, but also to manage those patients cost effectively and to prevent further cost of the health system. Additionally, Michael alluded to something Optum set up here in Cambridge, literally across the street, called Optum Labs. And Optum Labs is an initiative that is taking data and information, not only from Optum, United, other potential players in the healthcare industry, but serving as a place where research can be conducted to really examine issues that are germane to healthcare that haven't necessarily been the focus of a company or an organization, to research those questions, to develop IP, to develop opportunities that can then be taken to the market writ large and commercialized thereafter. So that's something that really will serve as sort of a hydrogen collider, if you will, of big healthcare data to spur other innovation.
How do people get involved with Optum Labs? What's the way for them to get involved?
So from a company perspective, there are organizations from all walks of healthcare, from life sciences to research, universities, et cetera, who really can reach out to the labs and talk about initiatives that they want to partner around and talk about things that they would like to potentially fund, if it's the case of a party that's interested in, or a grant that they'd like to pursue together. So really, the labs is an opportunity that is an environment that looks for innovation and looks for companies, parties, academics, et cetera, to partner around those things.
Do you want to? So, well, Charlie, you challenged us to try and provide some tangible value to the panel, which we're struggling to do. You mentioned incubators and accelerators. There's been this explosion of firms like Blueprint and Rock Health, and they're all wonderful initiatives. They're great on-ramps, but I think they're inadequate. And without insulting anybody, it's going to be efforts like Optum Labs that I think are the more appropriate on-ramps. Healthcare is so nuanced and complicated. It's hard for a 22-year-old coming out of MIT to start the next great healthcare coming out. It'll be a little controversial. They need to work in organizations and understand how the ecosystem works. Optum Labs, I'll give the commercial, I don't know how many people have been over there. It's an extraordinary place. Go hang out there. They don't charge you. They charge venture guys to hang out there. Yeah. That is a different category of exposure to the ecosystem, the innovation healthcare ecosystem than Blueprint or Rock Health. And they're wonderful organizations, but they're divorced from the complexity of that.
Right, and even though you talked about when you got it started, I think you guys had a strong track record already. The founders already had a strong track record in healthcare, right? Sorry.
Yeah, just yes. Several of the founding team have had successful ventures in the past. We were fortunate to raise a considerable amount of capital to get ourselves going and put the building blocks in place. So by the time we were opening the doors, we had a strong business plan, a strong management team, a strong set of partnerships.
Yeah, I want to just amplify Michael's point about the innovation being very local and sort of concentrated in some pockets. The flip side of that is to the rest of the world, the rest of the country at least, is so different that there I think you need to have the attitude that you should not make perfection the enemy of the good, and good the enemy of the not so bad, because small incremental changes go a long way. But to do that, you really do need to partner. And healthcare is one of those spaces where you can do something at a micro scale forever and not get anywhere. And that's one of the reasons why companies like Informatics, before they were really scaled up, Informatics was not a huge company when it was acquired, they get purchased because the IP is there, the technology is mature enough that it works and it's not sort of embryonic. And you'll see that trend continuing, and that's why there's so much venture investment going in, because what you do have to do is to get the right asset built, and then have the right model that can scale it up. But that model to scale up can be a different company, it could be Anyon. Anyon is a very acquisitive company. The company over the last 30 years has mainly grown through acquisition. So it's a huge number of acquisitions, and we continue to acquire companies. So I think having that dual view, which is what are you innovating around? What problem are you really trying to solve? Are you yet another Me Too big data company, or are you actually solving a problem that an Optum or an Anyon or an Aetna, the companies that are spending money in technology, would be interested in? I think it's a little bit of nuance there.
Yeah, so I think this is an excellent point, because an excellent discussion. Healthcare is a tough market in the sense that it's heavily regulated. There's two problems with healthcare. It's heavily regulated, which presents its own barriers for compliance and things. The other thing that's really hard about healthcare is that there isn't any institution that's in charge in general. Most healthcare transactions involve highly independent institutions, often adversarial institutions. So it's not just technologically getting them to share and collaborate, it's that they actively don't want to, for the most part. They either compete, or they have orthogonal or even adversarial goals in mind. That makes it difficult. If you go to a bank, I work in financial services, lots of other markets, you can usually find the center of gravity, and if you get a hold of them, you can do business and you can get things to happen. It's very hard to do that in healthcare, because you generally have to get multiple parties to agree simultaneously, and they don't work for the same people. So that's challenging, I think, very challenging, to your point about startup companies in general. We like to help startup companies. One thing, we're mostly a government contractor. We have a pretty sizable commercial practice and big data and farming things. But in both cases, we work with a lot of small companies, because it takes a village, it's kind of a cliche, but it almost does, to get these things done. There's a bunch of little companies. There's a company right here in Boston that we work with, very small companies, but very innovative companies doing social media analytics, various kinds of things. you have to have the right kind of relationships. One thing about government contractors is we do have whole programs that help mentor small companies and get them, because there's an enormous amount of complexity in dealing with government in general. And also, they require, government has small business set aside requirements that they absolutely have to fulfill, so we have incentive to do it. And we have people, you have to find the right person. I've been a venture capital person, a startup person, so I have some sense of what it's like to be on the other side of the transaction, if you will. And that helps if you can find the right people to deal with it. You gotta have, it's a good complement if you can work it out, because what we have is, we have machinery, we have the access to the clients, we have the understanding of the problems, and we have the need for the technology. So we have everything. And it is not trivial. I don't want to say it's trivial. It's the power web and the ocean liner problem. But that's a good combination if you can make it work, is to look for people who have that client access and, as you were saying, Michael, domain understanding, because we can tell. We can say, hey, look, we've got 5 clients who need this kind of activity, whether they're doing integration, underlying analytical integration for payers, or whether it's for ACOs, using kinds of private or combination things, doesn't matter. And of course, the government is just the flip side of that. It's doing the same kinds of activities to help these organizations or regulate them one or the other.
Great. Remember, you guys can always hop in questions, but what I'd like to get from you guys a little bit here is, to me, these stories, healthcare has always becomes a personal story, right? And we live in the area where big data problems, we're hoping help healthcare problems in the end of us. Do you guys have stories from anywhere that you think really illustrate well where the data analytics comes in to really help? I mean, we were talking a little bit about rural areas, but I mean, are there stories? I mean, I can start with one. One of my favorite stories that really I use to stretch people's mind and what we're talking about big data. I mean, when we talk, if you saw in the previous talk, they talk about the different attributes of data, volume, variety, veracity. But one that people talk a lot about is also velocity. And people are like, what does that mean? But we worked with a research group at a NICU, newborn intensive care unit, where they were looking at data coming off of those monitors. And normally they were every 30 to 60 minutes, we're writing down a value. Now, of course, all they were getting was a value every half hour. They weren't really understanding what was happening with the child by looking at the traces that were coming in real time. And there really wasn't a platform at the time to be able to do that. So we came with them, we had a research project with them to be able to look at those traces as they're coming off the monitor. Because, for example, if your heart rate is steady, if it's too steady, that's worse than if it just varies a little bit, right? And so what they were able to do was model infection. They had an infection model that they could see 24 hours earlier than what they were using by just looking at the traces in real time in a real-time model. So that was a problem that if they didn't have the platform to be able to look at a lot of data, right? Because these monitors are spitting out thousands of data points a second. So that's an example of how analytics in large amounts of data coming off of machinery, being able to model that. And now we've taken that to other hospitals who are asking themselves, what else can we model? What other physiological parameters we can model around stroke, around arrhythmias, around intracranial pressure? So I use that as an example of like stretching, an example of analytics that is actually changing the way we're doing care. I was just wondering if you guys had some good ones.
So we did one that is just coming to fruition right now, where we worked with the Midwest hospital chain, and we looked at sepsis. And so sepsis is a real problem if you're in hospitals. The mortality rate, there are four stages. If you get to stage 4, it's over 50%. Basically, 1/2 of people die if they get that stage. It's really just infection. Sepsis has just been a word for really bad ass infections. So they start out as minor infections often, and then they cascade and get really sick. And it's called sepsis and getting septic shock. So they had lots of, this was an integrated chain. It's about 40 hospitals, so they had about 10, 15 years worth of data from EHRs. And we took that data and looked at the progression from each of these stages, and were able to use that to create a longitudinal model that said, okay, if you look at their vitals earlier, just more often, really simple, low tech, just monitor their vitals more often earlier, then you can get them to prevent them from getting to these 3rd and 4th stages where mortality just goes up like crazy. And this is of interest to the hospitals. Again, partially it's of interest because there is this whole program on Medicare, which, since I work in Medicare, I know there no doubt, that penalizes hospitals for these hospital-acquired infections, but it also changes healthcare. It's saving people's lives already. These new protocols where you can, and it's not, often it's not the next, center that has 5 million things that can help, but it's just, instead of the nurses going around every hour, having the actual machine monitor, which monitors every minute or every 5 minutes, do the average and start to notice earlier, get the canary in the coal mine much earlier. Even an hour or 2 or 3 hours makes an enormous amount of difference when you're dealing with things like that. So that's one. The recommended paper that got my attention probably a year ago, and I thought was a great example of big data. It's something that we think about a lot, which is what we call letting the data talk to you. Because one thing that people do is they're hypothesis driven. So I have this idea and I go out and look for data. But the other thing is once you have a lot of data, you can start letting the data talk to you, if you will. So some researchers went out and did meta-analysis of a lot of clinical trials, and they were able to isolate drug interactions that would never have been in a clinical trial because they were made by different companies. It's very expensive to conduct a clinical trial. Now you can find drug interactions without a clinical trial just because there's large enough sample size now, large enough data set available that you can do it. That's, I think, tremendously exciting. And then, of course, the last thing is social media. So one thing that the government has noticed, for instance, is oftentimes prescription patterns change before adverse events appear. So somehow the diffuse community of doctors and patients has figured out that a drug is having bad side effects before enough of it bubbles up that you get the warning, right, and the FDA intervenes and all that stuff. So really interesting to talk about the velocity, right? Can you, because it's not just patients, it's providers too. Can you monitor the prescription patterns through the providers and the pharmacies and the payers to say, oh, looks like there might be something going bad here. Now you have to be careful all these times because it could just be that a formulary change happened and some drug got cheaper, everybody's being forced to take some drug versus another. But when there is an adverse event, there's a fairly high correlation to the prescription rate changing before the adverse event reaches the public. So those are the kind of things I think are very exciting.
I'll share one, something that we do actually at Anyon. I was going to talk about genomics and big data problem with molecular information, but since Gil touched on that in his keynote, I'll skip over that one. It's around fraud, waste, and abuse. An interesting use case is when somebody's not committing fraud necessarily, but submitting claims that are improper or excessive. Usually, it turns out that they're smart enough to not make it obvious to the payer that the claim is being submitted to, that it would just be, stopped. So, but if you look across payers, you'll notice a trend. So no single payer can pick up, for example, that a physician is billing for 26 hours worth of work in one day. But if you add up all their claims across multiple payers, you can actually see that this is just not possible. And then you can drill in and try to identify what's going on, why it's going on, and fix it. And literally billions of dollars in payments get made, without being caught. And this healthcare is rife with fraud, waste, and abuse all over the place. But big data is giving us a very unique lens on that. And it's a spectrum. So you find some really totally fraudulent people who should be in jail for submitting claims, but you also find physicians who are just trigger happy, and codes that should be level 2 or level 3 get coded level 4 and level 5. It's called upcoding. You get paid more for the severity of the visit. By looking at our big data, we can tell when a physician is an outlier, and when on the distribution curve they are way out of the end. Usually, there are things you can do to just educate them and say, hey, you realize that compared to your peers, you are way out here. And unless you really want to get audited, which won't be pretty, maybe you should go take that course on proper coding, or tell your staff to go take a course on proper coding. And more often than not, they change their ways. So this is another just boring, perhaps, billing and reimbursement-related use case, but there's billions of dollars at stake there.
Yeah, I think there's just without thinking of new use cases, just going back and looking at the data and just understanding patterns of behavior and efficiencies that just aren't being seen because we're not looking at the data that way, right?
Absolutely. So one of the things Informatica does, we solve one of healthcare's biggest problems, and that is we take data from disparate healthcare IT systems, the best of breeds that every hospital and provider organization bought at one time or another, and then we map and normalize all that data so it becomes apples to apples. You can now look across providers within our network and understand what's actually going on. In the clinical data, by and large, most organizations historically have had claims or billing data. So they see a diabetes code, they see what's been paid, so an ICD-9 code, a CPT code, and the information is directional but limited. With clinical data, you can start to stratify populations and learn about how medicine is really being practiced. So we take all this data, we clean it up, and then we run a basic report that says, in diabetes, how many patients not just have an ICD-9 code of 250, but also can we detect in the data based on their lab results, based on the drugs that they've been prescribed multiple times. In the unstructured data, the notes, we're able to pull out things like body mass index and turn it into structured information. We can first identify patients that are falling under the radar and slipping through the cracks. And lo and behold, in major chronic diseases, sometimes that's 20+% of patients in chronic disease in a given year are not being treated or coded as such. And no surprise, those patients are running up higher costs, more hospitalization, more ER time, etc. We've had some provider groups like Cornerstone Healthcare in North Carolina who ran a report on not just their diabetics, but those diabetics who are out of control at AAA, meaning their A1Cs were greater than 8, that's related to their blood sugar. Their cholesterol was over 100, and they were hypertensive, meaning they had blood pressure of 140 over 110 or greater. And they found all these patients weren't being treated on a regular quarterly basis like is prescribed by any basic type of medicine. So the ADA, all organizations related to chronic disease care would say these patients need to be seen on a quarterly basis. And so what did they do? They used their care coordinators to reach out to these patients, got literally thousands of them in the door, and started managing them. It led to a huge reduction in just a year of values of their A1Cs, improvement in blood pressure, improvement in their cholesterol. And we had physicians saying, I didn't know what happened. Patient was early diagnosis, and they didn't come back. I didn't realize they weren't being seen. Care, they were progressing in their disease rapidly. So this opened up a whole new door for many of these providers and many of these patients to walk through together to ultimately improve care. And we've had the fortune of using the data in another way. We talked about looking back at the data. So our clinical data is now about 40 million treated patients in the US. It goes back at least a few years, a minimum of 3 years, and in many cases longer. So we use the big...
Who's drooling over that number?
We use the big N, if you will, of all the patients by disease to look at things like what are the profile of patients that are being hospitalized in a given disease like heart failure. And we built predictive models that essentially bucket patients saying, if a patient meets these characteristics, there's a high probability that they're going to be hospitalized in the next 6 months. And we break it out by severity. And so providers are using that to now triage and say, we got to do something about these 500 patients, these 800 patients. Very bite-sized, chewable, if you will, areas to go after that they can improve in the treatment of care. And we have a large IDN in the Midwest that did a pilot across a number of hospitals, and they actually reduced hospitalization of those heart failure patients by 75% in just a 3-month period. Because now they had information at their fingertips. They could work again with care coordinators, partnering with physicians, partnering with their patients to make sure they got seen after a 3 days being discharged or 7 days, make sure they were taking their meds, call in for information, and this is where technology is only improving, where they have wireless scales that can start to send information or other data coming directly from the patient, where you can now manage these patients in a way that are going to save the healthcare system dollars, keep them at home in this case, and really improve outcomes in a significant way.
And you know, these are great stories, and but you know, we talk to the providers every day, and the gap. You know, what is the gap? You know, talk a little bit about the gap you see in terms of what we're not doing. You know, I think these are great stories. It makes it sound like, you know, everybody understands. You know, what is the gap? Is it savviness with data? Is it organizations are ready for this? You know, is it a technological thing? You know, do you guys have ideas like where are the gaps and how are we going to fill them?
In my past life at Oracle, we dealt with many of these challenges, and I think Alan can probably relate to that as well. A lot of the challenges today, you know, had their seeds maybe a decade or more ago, when a lot of systems got put in place that were closed architectural systems that got something done but were not architected to communicate with other systems. So we're still paying that price. But I think one of the big gaps is the skill shortage. You can get something done at Partners Healthcare if they got the money, they can hire consultants and they can afford out
and they're hiring 1,000 people to do a $1 million project, and there'll be nobody left to do anything else in the area, right?
That's, you know, it's a meaningful moving of the needle in terms of talent pool, right? These places suck up all the talent, and there's really, if you go out to the rest of the country and see how much horsepower they've got to rip out an EMR system and put in something new, there's just nothing there. So we need solutions that work out of the box, that don't require a lot of implementation, and it's tough to do these things. I'll give you an example of something we did, which I didn't think would have been a big deal, but people said, wow, you can do this? We went to a hospital in the Midwest, and it was actually a hospital system with a few hospitals and physician practices. And we had a lot of data on that region, and we were able to provide to them a complete view of what was going on in their patients without them having to do anything. No implementation, no integration, we just had the data. We have an MPI, we have fully integrated records across inpatient, outpatient, pharmacy, and lab. And we were able to actually give them the equivalent of a El Cheapo HIE. And I say El Cheapo because there's no deep clinical data there. It's not HL7 driven, and it didn't require millions of dollars of investment and a portal on top. But it actually told the physician that this patient was last seen by so-and-so, roughly at a high level. Here are the drugs that were prescribed, here are the labs that were prescribed. And by the way, these records sit in these locations. If you need them, you at least know where to go find them. And here are the major indicators. This is what the reimbursements were telling you. So it's not clinically accurate. Don't hold this up for clinical accuracy. But at least you know where the patient's been, what they had, what drugs they were taking, and a little bit of the history. That is a big deal, to be able to get that information, right? So going back to my point, not let the great do the enemy of the good. This is an example of something simple. You can fill a gap. But there are plenty of gaps like that in healthcare where simple solutions go a long way. But that's, doesn't necessarily attract VC funding, but I certainly think there's a lot of low-hanging fruit.
There's a question.
So
basically, I think that many people in the audience, we use big data or we use data. I don't know. We have the question of, like, you guys are collecting a lot of data. Many people are collecting a lot of data. Are there any plans to actually make available part of that data to the community, right? Because the community itself has other questions that the companies don't have, right? For me, for example, if I'm a particular patient, I want to know what patients are similar to me, right? To my history, my record history. So if I have access to the data, I can try to answer some of those questions. So are there any plans in the community to make available part of that data?
I can take a shot at that. So I think a big turning point is coming around patients being able to provide better consent. That's the biggest limitation, in my opinion. Everybody has data. Everyone wants to do a ton of things with data and share it. But consent and/or regulations like HIPAA prohibit most of that. And then underlying all that is also the unwillingness of most providers. So the more academic they get, the less they want to share their data. Getting data out of partners is next to impossible.
There's no shortage of academic hospitals.
And there's no shortage, right, in this area especially. When you go outside, I think, Alan can back this up. You go to medtech hospitals out in the country, they're much more willing to share data, right? But I think the fundamental problem is one of consent. And until you have consumer-facing apps that allow you the kind of control that you have over your Amazon account or over your eBay account or any other thing that you do or your bank account, in the palm of your hand, where you can provide consent seamlessly, easily, and with trust, I don't think we're going to turn that corner. But that's only part of the solution.
But I have a backup question. I mean, for example, if you go to a genomics lab right now and they make a screening of your tumor, they make a sequencing run of that. Usually, the data sits on the lab, right? You don't get the hardware to use it, right? As opposed to you go to get an X-ray, and then you get your plate, right? So the data is still in the provider, right? Even when I consent for like testing and all this.
Yeah, I would say I think this is a huge issue. I would say a couple of things. One is payers are maybe even worse than providers in terms of not wanting to share data. And because it's an advantage, it is an advantage. And analytics companies in general, that is why I said way back at the beginning, it's one of the biggest problems. Is right now, the healthcare system is 50% or more driven by economic profit. And so by law, those people running those firms have to maximize their profit. The way they maximize their profit is to have access to your data. That's what they do. And that is largely what happens. That's my personal opinion. I believe that's largely what happens. They're driven by profit motives. And so if they share their data, I personally think there is an argument that could be made, sort of a Google argument that says, hey, you share your data, the market gets bigger. That it has not obtained in the marketplace itself on either payers or providers. So that's a big issue. I think it will potentially change, but it'll probably take a lot longer. I did a debate with Gordon Bell, who's the founder of Incubators back many years ago. And we could have taken either side of the debate, which is how long will it take for broadband to penetrate. This is 1996. And for those who remember 96, we were mostly on dial-up modems at that time. And one of us said, like, it will take a couple of years. A lot of people were saying it will take a couple of years. All the technology was there. And the other side was going to take a decade. And it took over a decade. It had nothing to do with technology. It had to do with competitive forces and various marketplace things. And the healthcare is full of them. So I don't know how long it will take, but I think that it is quite likely that these apps, to Chris's point way back at the beginning, which I strongly agree with, it's awful, the interfaces in our medical devices and the interfaces that we have to deal with. In fact, I would say one thing is hugely lacking is user interfaces. It's the least attended to and perhaps one of the most important things. And with patients, with getting the consumers involved in control, that's what's needed is a simple way for them to get the healthcare.
No, I just, to get, your comment about the data sharing, I do see, so some software companies would say all the values in the software. I wouldn't say which company would say that, but maybe that one. But with the data space, we're seeing a lot of pharma who are putting clinical trials out there. They call it the competitive space, right? Where now they're
forced to do that pretty much, remember. That wasn't really all that voluntary.
But I think, when I talk to them, they all realize that having just a piece of that pie is not as bad as
it's still a tiny amount of all the data they have on their clinical trials.
But the whole idea of the value now becomes in the analytics and the speed of the analytics and how well you do the questions will ask, right? So maybe that might be a way for data to be liberated. People who have 40 million lives, 400 million lives over 40 years, whatever. It's like, how do we liberate that, right?
Yeah. Quick question. So thanks for the discussion. So in a very concise way, without using the words payer or provider, tell me as a human, in 5 years from now, how my medical treatment is going to be different. So I don't care about business efficiencies, I don't care about payers or providers, I care about me in 5 years. Reimagine what this means for me in a very concise way, please. Short answer that I can understand.
I'd like to hear from my professor because he sees the future. We are the past.
Just start with him. I just.
So I have no unique insight on this. I think the battle between P's is
Technical violation.
is one part. The person you buy services from, and around that person will enable that person to sell you content, insurance. I think that becomes. I think it's akin to what you see in financial services.
So I'm thinking more of the rise that there's all this telemetry. You know, if I'm wearing a fuel band or Fitbit and have all this medical history around me, how does that change my treatment? You know, that I get. So I'm a consumer. Yeah, I want to consume better treatment. What does that mean for me?
I'm pretty negative on those models.
So,
what can really can do in that space, and how far are we amazing real estate?
So, without using any of the taboo words, I think it's going to change because of the science. Everything else in that healthcare system that people obsess over mostly is a sideshow. It's all about money. But really the way your care is going to change is because of new diagnostics that can pinpoint what's happening to you at a relatively well-defined sort of biological level. It's not just your hemoglobin level or some little, or SNP in your DNA or anything like that. But at a systemic level, it will tell you where your system, your immune system or your neural system or your vascular system or something, or oncology, for example, detecting a single circulating tumor cell. It will tell you at that level of precision what's happening to you much before it becomes an acute episode, meaning before the cancer is detectable or becomes a metastasized tumor, or before you're ready to have a heart attack, or before you're even showing advanced diabetes. It'll tell you way early.
If there's a
ways
model.
to fix it.
So if there's a model.
Because of that, it's 10 years. The PPVs have to be convergent 100% to be.
So it's going to happen in progression. Some fields, some therapeutic areas will see low-hanging fruit being delivered, I would say, in a 5-year time frame. A lot of stuff will be 10 years out, there's no doubt. It's just a beginning. But it's because they're on an exponential kind of curve for these types of things, it's really hard to put a time on it.
And we need to be really careful of the fact that more data means better, right? I mean, we know that eat well, get some sleep, exercise are the basis of good health, right? We don't need Fitbits, we don't need 40 million lives of data to tell me that, right? I mean, we can do that. I know that you guys used to do like a natural history of diabetes and understanding, the causes so we can predict it early and get pre-diabetic. But, we know lose weight, exercise, that might keep you off diabetes. So we need to balance where the data is actually adding value to what we're trying to do. Sorry, that's just my little knee-jerk reaction there.
I think that we're likely to see a situation with a physician shortage growing ever increasingly dire in this country over the next decade or more, and more care being pushed out to community clinics, nurse practitioners, PA. I think the basics are going to be very circumscribed to, when you present with this is the protocol you will follow. It's not all going to happen in 5 years, but I think that is the direction that information allows the care to be put into that type of policy.
So ever improving the care guidelines through real evidence rather than
Real
just
world evidence.
Joe Doc, who's been a doctor for 50 years, saying that's how we always do it.
And certainly as patients get more complex and have comorbidities and other things related to disease, that's
second-tier organizations. So partners, NGA here, is the top of the rank in terms of academic hospitals. But the reality of standardized procedures and hard-ass payments is a second-tier organization that can prove through data that their results are as good as the first-tier organizations has an enormous advantage. And will start to generate enormous traffic going that way. Insurance companies and other people will start to drive people instead of going to partners to go to, I won't get into names here.
To pull that thread a bit, I think, where I see it, also maybe it's my hope, that as we get the systems working together, as we get people a little more savvy about using data within the care process, where we get these guidelines starting to be changed and having more evidence-based kind of thing, that slowly care will be a little bit more transparent, a little bit more cost-effective, a little bit more responsive, maybe not necessarily truly personalized medicine, but will at least be able to understand maybe subpopulations a bit better. And I think that's going to be a trend that's going to happen in fits and starts and spread out unevenly all over there. But it's going to happen because it's just a competitive issue now, right? Especially for these second-tier hospitals, they're going to be specializing in certain areas. They're going to say, our spinal operation is the best because, and I can show you why, and here's the costs that I know, and maybe even buying data from these guys and saying, I even know the cost of my competitors because I have a comparison. So that's going to change. The use of data on a day-to-day basis is going to increase. And I think the quality of data is going to go up as people start using it because they're going to realize it helps them provide care. And so we're going to have, I'm hoping to see an increase in the use of the data. It's not going to be, we're going to have a great system, but we should have more evidence-informed kind of care.
And make a quick point about timing, right? I think everybody talks about healthcare and what will happen in 5 years or 10 years. It's navel-gazing, right? But if you really think about disruptive changes in any industry, and particularly now in healthcare, I think they're hard to predict. And when they happen, and they will happen with some consistency over the next decade, you will see very significant improvement in different areas. I'll just cite one company called Theranos. How many of you know heard about Theranos? There's a Silicon Valley biotech, a healthcare startup actually, and they provide a blood test. The same blood test that requires 3 or 4 vials of blood when you go see a physician for an annual physical. They'll do that entire test with 1 drop of blood. 1 drop, and they'll tell you the result within 3 hours. And they can check 200 different things from that 1 drop of blood. And that's live today. And they just partnered with Walgreens. So that now, instead of going into your physician's office to get your blood drawn and spending, a pint of blood and waiting a week to get the result, you can go to Walgreens, get a pinprick, and get the same result back for half the cost, right? So these things do happen. I don't know how fast it's going to take off. It'll be, crystal ball gazing again. But these kinds of breakthroughs are actually imminent in quite a few, surprising number of different areas of medicine. It's just hard to predict whether they're going to sit there for 5 years before there's, the real breakthrough. But we are really close in many areas. I for one, am much more optimistic. But that just may be me.
So, I saw a hand up here earlier. So it was, sorry.
Okay, thank you. I guess implicit in this conversation has been, how do we fill the gap? And what I'm hearing from you is that it's going to be a conversation around standardization. And I think that the systems in place are to disseminate ideas really lack. So, for instance, it's hard to disseminate insights through peer-reviewed journals. I'm not going to do that. I have a full-time job. Similarly, I don't sit on boards to help develop care guidelines, but I learn about people's health data and how to improve care delivery systems every day. But I don't have anywhere to disseminate those findings anywhere other than my workplace. And so I'm wondering what systems you think would develop that need.
So I can speak to, with our partnership with the American Medical Group Association, one of the things that we do is we hold the AMGA Drive, shared learning and collaboration between its members. So we actually convene live a couple times a year, and the various provider organizations come together not only to look at variation of care and best practices between and amongst the groups, but also to learn from one another and see what investments were made to achieve those outcomes, what worked, didn't work, what definition should be common amongst all the groups. Like, how do you really measure blood pressure? Is it the last reading? Is it the last 2 readings? Is it 3 readings over a period of time? Because blood pressure can vary so often depending on what you ate, whether you're having white coat syndrome, etc. So I think there's going to be more and more shared learning as that becomes easier to do. It doesn't always have to be live meetings or webinars. There'll be, I'll call them less academic peer-reviewed journals that will disseminate this real-world data based upon what's seen in the information, while leaving many questions that need to be studied further and answered. So I think things like that will be one means of disseminating information about what's really happening and what information should be given, but that won't be it. I don't know if you've seen some companies that do interesting things.
I would say that, if you have a great idea, start a company and talk to Richard or Michael. And if you can't do that, if it's not an idea of that type, talk to companies that can enable that idea. And I would say a great place to start are consulting companies. They are with customers. I mean, you mentioned, process improvement and, ideas about how you can change things inside the hospital. If you're seeing that every day and you've picked up on something, talk to people who do process transformation. There's a huge community. IBM does a lot of that work. So does Booz and many other consulting companies. And they'll listen to the idea. It's not hard to get to these people. And if there are other companies, startup companies or even big companies, I think in this kind of a neighborhood, it's not hard to find people who will pick up on that idea. And even if they don't know what to do with it, they'll put you in touch with somebody who knows somebody who'll know what to do with it. So if you have great ideas, I think it's a great time to be sharing them and doing an outreach.
The topic tonight was about analytics and big data. Wouldn't the coming of the ACO, at least in theory, if it works as advertised, help drive more diagnostics, which in turn would be a big driver for big data and analytics and predictive outcomes?
Yeah. I think ACOs will be one of the biggest drivers initially. Again, we haven't really defined big data, so it's a tricky wicket there. But I certainly think they have a fair volume because to be an ACO by definition, an ACO is an integrated organization, right? That they typically tend to take one payment for either taking care of one condition, like doing hip replacement, or taking care of a patient for a year, 2 years, or 3 years. So you're going to get a big thing, you have to divvy up and figure out how to do it. So needless to say, analyzing the cost and the results of your care is pretty important in that environment because you're now taking basically your insurance company, right? You're taking a lot of risk. And so yeah, I think that's going to drive a ton of things. It already has in work that I've already seen. Simple things, again, like a knee replacement. The understanding of how quickly somebody gets into rehab can change hospitalization by half a day or a full day. That's a huge expense in a knee replacement. And actually lends more functional response and makes the patient healthier generally as well. So things like that, I think, will drive a lot of stuff pretty quickly. And I think that Chris is right that the diagnostic tests in general can change things rather rapidly. The personal sensing things that are possible now are moving quite rapidly. It's just hard to say how fast they will move it. I would agree. It's very hard to predict. If you want to make a bet, I bet on longer rather than shorter.
Yeah, what we're seeing is that just to get to the point of doing those reports, right? Because these are just reports. You don't even get fancy on the predictive side, right? These are just reports and seeing what's happening in an organization. To get to that point, there's so many pieces that they have to put in place to get their data management pathway in place. That will then allow them to do so much more after that. So what we're seeing is people are struggling to get that starting line to do the reports that they're required to do. But once they get there, they're going to be able to start doing other things now that they have those data paths coming in and being able to look at other things that's happening in the organization. So yeah, it's a heck of a motivator.
Yeah, I would nuance that a little bit. I think there's a part of the ACO equation that maybe sometimes misunderstood. ACOs are not necessarily going to drive better therapies or even more diagnostics, because actually the reality is diagnostics are sometimes overdone. They're more expensive ones. They're way more wasteful MRIs and X-rays and CT scans that are done than the converse, right? But what ACOs will do is give providers and payers the motivation to use the data that is being generated very, very well. So they'll collect all the data which they're not collecting today. They will integrate all that data, and they will use it very aggressively to make the right decisions. They're not necessarily going to be clinically oriented all the time. Sometimes they think low-hanging fruit is really just cutting out the waste. Right? Stay home, don't go in. Instead of staying in the hospital, go stay home. Your chances of not getting an infection are better, and you'll have the same outcome. Those types of things, I think, is where you'll see most of the near-term ACO benefit.
I would just add one caution around ACOs, and that is for all the promise that they offer in terms of bending the cost curve, improving quality, and managing patients, understanding how to manage risk is not easy. And many provider organizations are ill-equipped to do so. It's going to require difficult choices at times. It's going to require a free flow of information that is not going to exist in a perfect world. They might be moving towards the start line, but when they start and press go, we've had ACOs that are at risk that don't have the denominator. They don't know what they're managing towards that risk. And I expect the road will be littered with many failed ACOs along the way who make big mistakes unknowingly or unwittingly, but nonetheless, it's a difficult problem to solve. What happens when you have in your high-risk pool patients that you mismanage? Do they have the balance sheet, like an insurance company does, to handle those patients that fall outside their expected norms?
Yeah, that's the organizational part of big data, right? So it's not just about the data, the technology, but do you have an organization that knows how to share data, knows how to deal with the results that come in, they have the skills in place, and we talk a lot, in fact, in the 90s, they used to talk about numerous people who knew about mathematics. I think, we need data literacy, people who understand what the data is. And, I go to all these meetings, and people talk about data, and a lot of us who are data heads, we think these fancy algorithm dice, regression and all that stuff, right? But in the end, some of these guys, all they want, these executives, all they want is a green thumb up and a red arrow down. And they just want to know, what happened since last time. They don't care about it. To them, fancy visualization is a bar chart, right? So we have to keep in mind that as well, that all this stuff that we're thinking here about big data, at the end, and the people who are consuming it, there's a certain savviness that they have or don't have that we have to understand, right? So,
I think one thing we haven't said. Again, one thing we haven't said, so one thing I would say is, it's not hard to get started with this stuff. It's like, really, we can usually do something in a month. Sometimes it takes 2 months if it's really tough. And that's one of the biggest, nicest things I think about, what I think of as big data. And so I'll be a little more careful, which is we ingest data and put it in a place that's pretty flat. It's not all that structured, it's not a data warehouse. And then we run the analytics against it afterwards. So that's a critical change from the normal process, which is you spend like 6 months cleaning, soaking, and washing, whatever, and then the data's finally ready for somebody. That's a huge difference. And the ability to get, like you said, most executives don't have a lot of time. I'm an executive, I don't have a lot of time. Okay, I understand stuff, I still don't have a lot of time. The ability to do it quickly and get results quickly and show meaningful activity on real data in a few weeks can change things rather rapidly. And so don't write a lot of papers and do a lot of research. Find some interesting data with an interesting problem. Find some people who know how to do something with it, and you can get results pretty quickly. And that's the best way to get started.
I think that's a great way for us to wrap this up. I want to also, one thing that I wanted to get out here is some sort of, action item for you. So the first one being, it's easy to do, just go out and do it and find something, right? So just to summarize it, so find something.
Find a problem, right? That's what the point was.
Right.
Ultimately, it has to be a problem. The hardest part is finding the problem that you pay attention to. And then you can usually find your data.
So your action is like, just go out and just do it then. Yeah. And I mean, it can't be that one, it has to be a different one.
Darn.
Yours could be hard, so they'll use 3 of them. The action, some of the action is people like to think about when they go.
Do your part as a consumer, would be my suggestion. There are a lot of empowering tools coming down the pipe. They're not here yet. There's some already out there, but a whole lot more coming down. I mean, the next 12 months. I personally know at least half a dozen great tools, apps, or devices, just like a Fitbit and devices like that are getting better. Use them and actually try to use the data. I think everybody here is data savvy. And then try to play a part in the health system, dealing with their physicians, and try to help, get their mindsets even to change. Because unless they hear from consumers, they're not going to feel the importance of consumers. So as long as consumers begin to expect an Uberized experience, I think it's going to, only get us there faster. So that would be my suggestion.
Yeah, and I was at a big CIO conference, hospital CIO conference, and they were all talking about what they could do in the hospital. And my question was, how many of you would do it, right? So we're all consumers here, and I think we kind of forget that. We're like, we're going to make some beautiful thing for these patients, but in the end, we're all patients too in some way, and we have to ask ourselves what we want. So I think this, do we want an Uber experience? We should all demand it, build it, right?
Here's something even more specific. Think about a high deductible health plan if you don't already have one. Actually, a lot of economic rationale.
People often say that healthcare is 20, 30 years behind other industries when it comes to the adoption of information technology and call them more modern techniques of using big data and information. And while there are certainly situations where that's true, healthcare is also a lot more complicated. If you get things wrong, people die. And so there's a need for high precision, high accuracy. The complexity is only getting worse as we move from ICD-9 to ICD-10, going from 20,000 different variables to literally a 5x increase in what clinicians are being responsible for. So I would urge people to think creatively. Think of how problems have been solved elsewhere and apply some of that genius to healthcare, recognizing that it's a convoluted healthcare delivery system where oftentimes, even if they're in a high deductible plan, the patient isn't feeling the full breadth of their decision, and there are gatekeepers called clinicians and physicians and so forth, and there are all different touch points along the way. So we need a lot of creative thinkers and people that bring knowledge and various expertise to solving a very complex problem.
So I would say I'm obsessed right now about figuring out how to crack the great unwashed home healthcare market, to your point on standardization, and the dual eligible. So those are two specific things that we're trying to figure out. And then I think my advice to anybody in the audience who's an entrepreneur is take advantage of the concentration and talent. I'm always happy to see somebody for 20 or 30 minutes, get access to venture investors, these kind of executives, and just immerse yourself in the ecosystem.
Awesome, guys. Thank you so much. This was awesome.